Hello everyone, I'm Dr. Angela Mackey and you are watching Ask the Mayo Mom on Mayo Clinic's Facebook Live. I'm a pediatrician at Mayo Clinic Children's Center, and twice per month I host a show about pediatric health topics where we take and answer your questions live. We will be having two experts joining us today for a discussion about spina bifida in children. The first is Dr. William Shaughnessy and the second is Dr. Sherry Driscoll. Dr. Shaughnessy is a pediatric orthopedic surgeon, the director of the Cerebral Palsy and Spina Bifida Clinic at Mayo Clinic Children's Center, and also an associate professor of orthopedics. Dr. Driscoll is a pediatric physical medicine and rehabilitation physician, also known as PM&R, and assistant professor of physical medicine and rehabilitation. It's going to be a great discussion today, but it's even better when we get to review questions directly from you. Please send in your questions under the Facebook Live video feed, and we will try our best to review them during the live video broadcast. So, Dr. Driscoll and Dr. Shaughnessy, thank you so much for joining us today.
My
pleasure.
It's going to be a great discussion, and I hope to learn a little bit more about spina bifida as well. Let's start off by having Dr. Driscoll. Why don't you tell us a little bit, what is spina bifida?
Spina bifida is a condition that infants are born with, so it starts in utero, and it's a defect of the way the neural tube or the spine forms as an infant develops. And so when the baby is born, the most typical thing that happens is that there is, and I think we have a picture of this.
We do, absolutely. Let's take a look at that.
There is a defect in the back where there's an outpouching of potentially both the nerves and the spinal cord that protrudes on the outside of the back, whereas in a normal situation, everything would be inside the back and enclosed in the bones.
Absolutely. So how does this present, and what would be the causes of this?
The causes still aren't truly known, but it's thought that up to 60% have a genetic contribution. We also know that the vitamin folate has a big role to play in the formation or the development of spina bifida, which is why it's recommended that women take folate when they're of childbearing years. But ultimately, I think the studies are still ongoing as far as the specific cause of spina bifida.
Okay. Dr. Shaughnessy, so I should have asked you this question. So how do we diagnose spina bifida? Is this something that we're going to find out prenatally, or is this something that we find out after the infant is born?
At least in the last 10 years or so, maybe the last 15 years, almost all children with spina bifida are identified prenatally based on that 20-week ultrasound that's typically done as a part of routine prenatal care. Of course, if a woman doesn't have any prenatal care, it's very possible and likely that the child is not diagnosed until they're born, and then it's visible to everyone that's present. But in virtually all cases now, at least in the developed world, spina bifida is identified based on a prenatal ultrasound. Now, it's important to know that this is a failure of normal development. So the spine develops out of a flat surface. Imagine a piece of paper that curls up during development, and that happens usually in the first trimester or so. So it takes until maybe the second trimester to actually see this on an ultrasound as a defect.
Okay. So the defect is the baby's born and the defect is apparent. How would this go about being repaired, and what's the timing of that?
Yeah, the history of spina bifida is kind of interesting. Back in the era before 1950, most of these were not repaired, and the children died. About 95% of them passed away and died, usually from infection or hydrocephalus, a collection of fluid on the brain. Since then, virtually all children have a repair done by a neurosurgeon in the first 24 to 48 hours of life. And that's a surgical procedure. That the children, the babies, are taken to the operating room. The sac on the back is closed, and the bones are not repaired, but the sac is closed, and at least that eliminates the risk of infection. And that is an operation that happens early on. In the last 5 to 10 years, that operation has been pushed now into the womb, and prenatal closures are starting to be done, not necessarily on a routine basis, but certainly more frequently than in the past, where somewhere around 30 weeks of age, or maybe just before that, the mother would undergo a surgical procedure where the defect is closed while the baby is still in the womb back in the uterus, and the uterus is closed, and then the mother carries the baby to term. There are some advantages to doing it prenatally, the most important being a decreased risk of hydrocephalus, which is fluid on the brain, and perhaps a little better neurologic function.
Okay. And that's something that we are starting to do at Mayo Clinic as well. And,
Yes.
and something that hopefully on the show we'll be able to talk about at a later time with some of our fetal surgeons that are doing that procedure.
Yes, absolutely. We're doing it here, and our early experience is that those two goals that we're trying to reach are being seen.
Absolutely. That's fantastic. Dr. Driscoll, I'm going to turn back to you now. So do all children with spina bifida, are they going to require care by a multi-specialty clinic, or can it be done just by one doctor taking care of all the concerns that may come along with it?
Really important for all children with spina bifida to have a multi-specialty intervention or multi-specialty clinic. I guess I should differentiate that what we're talking about is a myelomeningocele, or the outpouching that we showed the picture of earlier. We're not really talking about spina bifida occulta, which is a common, more incidental finding in the general population that doesn't cause neurologic problems. But because the children with myelomeningocele have potential problems with neurologic structures, orthopedic problems, problems with their bladder, problems with their bowel, they need to be seen by a variety of different providers to maintain their health. And one of the most important things that we've found over the years since individuals with spina bifida have started to have normal lifespan is that care of the bladder is absolutely critical. So that the children don't go into renal failure. And we'll get to that later, I think, in the conversation. But that's just one example of why it's so important to have multiple people involved in the child's care.
Absolutely. So Dr. Shaughnessy, as a director of the cerebral palsy in the spinal bifida clinic, who are some of the specialists and the nurses and the people that are involved in this care team of making sure this child's health is being addressed in all aspects?
Yeah, it's a good question. It's a big group. You can imagine that if nothing worked below your chest or your waist, you can imagine just the type of problems you might have. And it includes a whole list of people from, as I mentioned, the neurosurgeon early on, and the neurologist who helps us determine whether the nerve function is changing as a result of other problems that might be going on. As Dr. Driscoll just mentioned, the biggest problem that we see in the adult population now is difficulties with urinary tract infections in the bladder and bowel. So the urologist is a key figure in this care. And then orthopedic surgery for the limbs and the spine are also very important, as well as physical therapists, occupational therapists, help with bladder and bowel problems. So the list goes on and on and on. We have currently, I think, about 8 different teams that are involved, plus sort of supplementary care from social workers who have to deal with the healthcare resources that we have in our current situation, and nursing care to handle all the patient phone calls and the questions that come in.
Because I imagine not many patients actually live within our community area, and you're seeing patients from a large catchment area. Is that correct?
The incidence is about 1 in 3,000 births.
Okay.
And in Rochester, Minnesota, that's about how many births there are a year. So you typically only see 1 or 2 kids that are born here in Rochester each year. But if you expand that area to, say, 5 states, the number of kids you get is a fairly good number. And there are limited numbers of centers around the country that deal with this.
Absolutely. And I'm guessing they're mostly going to be at academic centers. Is that correct?
Yeah. The problem is that as an orthopedic surgeon, I can't take care of the bladder and bowel problems.
Exactly.
Nor do I have the expertise to do so. So you have to have that group of people around, and typically they are employed by academic medical centers.
Absolutely. Well, I can imagine if my child was being seen, I'd definitely want them to be seen at a clinic who has experience seeing children, and the ability of the resources to help coordinate all the care together. So that's fantastic. Dr. Driscoll, let's have you talk a little bit about some of the other concerns. So we talked about the initial defect and how that needs to be closed, but as a result of that defect, there's a lot of other medical concerns. You mentioned bowel. Dr. Shaughnessy mentioned other things like hydrocephalus. So let's kind of go through those, starting with the neurological concerns and
Sure.
understanding why is it important to understand where the level of the defect is at and how it can affect the child's symptoms.
So the level of the defect is important because it will give you some sense of what the risk is for other complicating factors. So for example, a child with a very low level lesion, let's say it's down in the sacrum, very low in the spine, will have less a likelihood of developing hydrocephalus, for example.
Okay.
Or some of the more severe orthopedic consequences, for example. Whereas a child with a higher level lesion up in the thoracic spine, mid-spine, or especially up in the neck and the cervical spine, which doesn't happen very often, but the higher the level of that lesion is, the more medical complications you might expect.
I think we have a nice diagram of this. If we could pull that up and we can show how the levels do affect. Perfect. Can you walk us through this diagram a little bit?
Sure. So this is a picture of a back of a little girl, and we are depicting the different spinal levels where the spina bifida lesion might occur. And the most common is for it to occur down in the lumbar spine. That's the vast majority of individuals with spina bifida will have it somewhere in that region. Some will have it, like I mentioned, down in the sacrum, and then there are others up in the middle of the back and neck. And one of the things that level helps us predict is what the neurologic or functional outcome of the child will be. So, for example, if a person has a thoracic spina bifida, the likelihood of their legs moving on purpose, volitionally, or them being able to move their legs on purpose is very low. And so the likelihood of walking independently is also pretty low. Whereas if the level is very low in the spinal cord, down in the sacrum, most of their muscles in their legs will function pretty well, and it's expected that they'll be able to walk in the community like their typically developing peers.
So you were probably addressing this question very early on with the family as they get this diagnosis.
Absolutely,
will their child walk?
Right. That's one of the things that we're looking for as we're just observing a newborn baby in the NICU. We're looking to see how they're moving their little legs, what muscles are activating, which muscles seem more still, what the position of their legs are, because that gives us a hint about which muscles were working in utero even and which muscles weren't. And so we try to sort that out early on, although it can take some time to be more definitive about how that's going to turn out.
Okay. So there can be other complications that can happen within the spinal cord. Can you talk us a little bit about those? And I know you would kind of mention if it was higher up, it could be things like hydrocephalus and stuff.
Hydrocephalus is actually really common in spina bifida. So in years past, decades past, well over 80% of individuals with spina bifida require a shunt for the extra fluid that builds up in their brain for that hydrocephalus to manage that. These days with the fetal surgery, we may be reducing that incidence a little bit, which would be wonderful because there can be a lot of complications from shunts and hydrocephalus. So that will be a tremendous outcome should that come to fruition. As we work our way down a little lower than that, there's a complication called Arnold-Chiari malformation. And basically what's happening there is that the base of the brain is pushing down a little bit lower than it should be, down into the foramen magnum, or an opening at the base of the skull, down into the cervical spine area, and things can become compressed there. It's a common finding, but it's not commonly symptomatic.
Okay.
So that for the children that do have symptoms, they might involve things like swallowing and talking and that sort of thing. And it can be a fairly severe complication if it is a tight or a...
So that's something you would probably find out right away, but not necessarily know if symptoms are going to develop or not necessarily.
You sometimes would find out right away, but not always.
Okay.
That's something that we watch for over time. That's another reason to have frequent check-ins to look for any sort of neurologic complication that comes up along the way.
Absolutely. And as a general pediatrician, I want those checkups to be done with a specialist that are really specifically watching for a lot of those symptoms.
Yeah.
We can help, but that's just the benefit of having that multi-specialty clinic and having that routine care.
Right. There are a couple more things that I should probably mention, if that's okay, as we work our way down,
Yes.
that are sort of in terms of complications or neurologic problems that can arise and are common. One is a syrinx, which is a little bit of a fluid-filled space within the spinal cord itself. Often doesn't cause any problems at all, but occasionally does. And so that's something that we monitor for. And then a later complication that can develop in some children is something called tethered cord syndrome. That can cause symptoms such as pain and increasing weakness and rapidly progressive scoliosis. And again, doesn't occur in all children, but it's something that we monitor for and can treat if needed.
Absolutely. Well, you mentioned walking earlier, and some children may be more likely to walk and others may not. But what kind of things can you do to help the children in this process as they are learning to walk?
Great question. There, I think, are a lot of things that we have to offer for children to improve independent mobility, and that's really what it's all about. So whether a child is walking independently, whether a child is using braces or orthotics, or whether a child is mobile from a wheelchair base, it's all about independence and exploration and getting them involved to participate in all the normal childhood things that you would want your child to participate in. And so things that we have at our disposal would include therapies. So physical therapy is critically important. A home exercise program that parents can learn and work on with children can be helpful. We have splints and braces that we use, depending on the level of the spina bifida and the need of the child to give extra support in their legs to stand and walk. There are all kinds of gait aids, from canes to different types of walkers to much more substantial devices that can give a child the ability to walk if that's something that the family really desires to push, even though it's really can be quite a challenge for the child. And then, of course, mobility devices, all kinds of chairs and whatnot that can really maximize independence for a child.
Absolutely. What about in the school setting? Are there other things that can be done to maximize their mobility or their participation in being able to do sports along with their peers?
Yeah, that's something that we really encourage because we want all kids to be active and participate in a wide variety of activities. And so the school can help by sometimes providing physical therapy to look at the access for the school. What about the stairs? How about an elevator? How do you get from the lunchroom to your classroom? Can you stand in your classroom? That type of thing. We can enlist the help of adapted PE teachers, and basically what that is a person who is specially educated to provide an inclusive atmosphere for a child with whatever disability, be it spina bifida or something else, so that they can participate in physical activities. And then there are just a number of resources in the community through adaptive parks and recreation, to numerous camps for kids with spina bifida, and activities for children with disabilities that can be accessed. And if I may, I'll just put in a plug for the Spina Bifida Association. They are a national organization that helps children with spina bifida, and they have a great list of resources on their website in terms of camps and activities for kids.
Absolutely. Well, as we're talking about walking, I want to bring Dr. Shaughnessy back into the conversation, talking about some of the orthopedic complications that can develop. You mentioned scoliosis. Can you talk a little bit about what you are seeing the children for?
Sherry mentioned a couple of things that determine the number of problems they have, and the level of the lesion often dictates how involved the kids are and how much we need to do as orthopedic surgeons. The luckiest kids, the best ones, the kids who have a defect way down in their sacrum, part of their pelvis, often look to me as an orthopedic surgeon completely normal. They walk, they run, they jump, they play, and they have full movement of their upper and lower extremities. They may have bladder and bowel problems, they may have hydrocephalus, but from an orthopedic standpoint, that they may do really well. On the flip end are the kids who Dr. Driscoll mentioned have these thoracic or cervical lesions that are way up here at the base of the neck or in the chest region. And almost by definition, those kids are going to have lots of problems. They usually can't move their legs. They can't feel. We'll talk about that in a little bit. They usually don't walk because the motor function in their legs just isn't there. And so they can develop all kinds of different things that we end up taking care of. Club feet are probably the most common, where the feet are just deformed at birth and often require surgical treatment. They can also have what we call contractures, where the knees or the hips are stuck in a certain position and don't run through a normal range of motion.
Okay.
And then they can develop spine deformities as well. The incidence of scoliosis, meaning a curvature of the spine, among the kids with spina bifida is overall about 40%. So it's a pretty big number, much larger than the normal population. Those typically don't develop at birth. These are things that the kids acquire over time. And then they develop hip problems, knee problems, you can name it. There is even a condition where, because of the lack of sensation, can't feel below a certain point, that the kids can traumatize their extremities because they don't feel pain. And so we've had some children, for example, where well-meaning siblings are trying to get the knees straight, for example, and break the leg or injure a joint. And that is almost unique to kids with spina bifida who don't have sensation.
Let's talk a little bit more about that sensation. And I think we have an excellent graph that helps us understand where the lesion is at and how that can affect what the child can actually feel.
Yeah, if you could imagine on this picture that the defect in the spine is anywhere along that light gray in the chest and waist area, the farther down you go, the more sensation you lose. So for example, if you had a lesion right about where the breasts would be on that figure, you would not have any feeling below there, or you might have patchy feeling below there, which makes things like as simple as bathing difficult, because now you have trouble getting into a bathtub, and now you have trouble feeling the temperature of the water, which might be too hot and could burn your skin. Whereas if you were really, and it's maybe the wrong word to use, lucky, but if your lesion was way down at the base of your spine, near where the buttock is, the sensation loss might be only that really dark gray area, part of your calf or the back of your leg, but you might have pretty normal sensation in the rest of your legs. And those kids actually do quite well. They all have troubles, as you can almost guess, with their toes, their feet, their ankles, getting sores. If they do walk, and most of the kids do walk, they can get blisters and sores on their feet. During this time of the year, we often see, and this is a little bit good and bad, the kids who go to the swimming pools, you've probably seen outdoor swimming pools, a lot of times they have a surface which is the bottom of the surface, which is almost like sandpaper. It's meant to keep you from slipping.
Yeah.
Well, for a child with spina bifida, it is sandpaper, but they don't feel it. So they'll rub their feet and their legs and their ankles on those surfaces and get sores. And then they get out, and of course they're bleeding, but they don't know it till they see it. They don't feel it. And so those sorts of problems are common, and there's a lot of learning that has to go on. Simply the use of water shoes often can alleviate those problems, but it requires some knowledge and some creativity to actually prevent that sort of thing from happening.
Absolutely. What about in other settings? How can they prevent injuries to the skin areas that are
Yeah,
insensate?
the most notorious ones are the so-called sitting sores. A child sits in school all day, and if you put a child with spina bifida and decreased sensation on a regular wooden school chair, they're going to get a sore right on their buttock. And that used to be very common. It used to be a horrible problem. The cost of treating one of those is enormous. But now we have, and Dr. Driscoll can speak to this too, we have cushions and seating supports that really minimize that. And with good care and careful planning and reasonable equipment, those problems can be alleviated.
Absolutely. Do you have anything more to add on that?
Yeah, I would just add one of the things that we like to do is teach both kids and parents to monitor skin. And so just simply taking a look at the entire child's body, morning and evening, is a good way to just keep an eye on things and make sure that a sore doesn't develop. If a sore does develop, they can be slower to heal than you might expect. And if they become infected, that can just lead to a lot of other problems that we really try hard to avoid. And so prevention is key. So making sure that if they wear braces, that their orthotics fit well, that they're adjusted for size and growth, that their shoes fit well, that there are no little rocks or anything else like that caught in there, and that they have a nice soft surface to sit on is important.
Absolutely. We have an audience question about bladder and bowel concerns, and so let's move into that area a little bit more. You mentioned in the beginning about some of the concerns. Can you tell us a little bit more about the concerns that the children, depending on where their level of defect is at, it may experience?
Sure. Bowel and bladder is innervated at the very bottom of the spinal cord. And so almost all, 90+% of children will have what we call a neurogenic bowel or bladder, or both probably. And what that means is that they may have less ability to control their bowel and bladder than their typically developing peers. And we have a variety of different ways that we can address those problems. I've mentioned that urology is a key important clinician for these children and as adults with spina bifida, because we want to make sure that their bladder is managed safely in a way that keeps them clear of infections, keeps their bladder from having too high of a pressure, it keeps their kidneys safe from any damage, and also helps to maintain continence so that the children aren't incontinent. We do a number of things to make sure that children can get out of diapers on a reasonably normal schedule, and their bowel and bladders are managed a different way.
Okay. And what are some of those things that you do or that the urology team is participating in?
Depending on how the bladder acts, and you figure that out by a number of bladder studies that the urologists utilize, you can either use medication or commonly a clean intermittent catheterization program. And basically that's where you insert a catheter in through the urethra to the bladder to empty the bladder and then remove it. That's something a child can learn to do independently as young as 5 in some cases, on average about age 9. But it depends a lot on how the bladder acts, whether or not that's appropriate.
Okay. What about cecostomies? When are these indicated?
So the bowel is kind of a different story. The bowel can impact bladder and can impact continence, and the bowel most commonly can get very backed up. So children with spina bifida have problems evacuating their bowels and or being continent with respect to stool. And so very early on, the most important thing that we do is make sure that they don't get too backed up. We make sure that they aren't too constipated. Often we'll supplement with prune juice or something simple like that. Many times it will take something more significant like medication such as Glycolax, that type of thing. By the time usual potty training years come around, we're thinking about how we can introduce a bowel management program for that child to help introduce, true potty time, so that they can stool on the toilet rather in a diaper. And we will try some things early on that may or may not work. Occasionally they do, so we do go through it. We could try suppositories. We could try little mini enemas. But often these things aren't effective because the tone of the child's rectum is just very lax, and they can't even hold a suppository or a little mini enema. And so then we move on to something called the cone enema system, which is basically just a fluid flush of the bowel, and then allowing the child to stool on the toilet once a day. It can take some time, but it's usually very effective in keeping them then clean and dry over the next 24 hours. Sometimes we can go to an every other day program. There are a couple of different systems that are similar to that we can try. But if that's working well, but family doesn't enjoy the process, which is often the case, then another option is the cecostomy. And so that would be the Chait tube, or more of a natural anatomical conduit, basically, to the outside of the skin. It's a tube that goes from the right side of the colon down over through the left side, and then so the stool basically is flushed in the anatomic direction, antegrade, or in the normal direction, and then stools on the toilet. Again, provides a pretty decent clean out, usually clean and dry for the next day, and good to go.
So it gives the kids a lot more independence at school.
Absolutely.
And to be able to not be identified as different than the typically developing child.
Exactly.
Yeah,
Yeah.
absolutely. That's fantastic. Well, we are getting very close to the end of our time. Is there any resources that you guys, other than what you'd already mentioned, that you would recommend for families? Any camps or anything like that?
Depends on which part of the country you're in,
Yeah.
and there are a variety of number of spina bifida camps that are held around the country that get these kids together. They share resources, they share stories, they share tricks that they've learned in dealing with any number of these problems. And the Spina Bifida Association of America coordinates a lot of the sharing of information and is very good at providing information to parents.
Fantastic. So parents should go to that website and look for it, and also talk to their local spina bifida clinic. Whoever they're being seen would also probably be a good resource for them.
Absolutely.
Okay, sounds fantastic. Well, that is all the time we have. Thank you both so much for joining us today. It was wonderful. You can catch the next Ask the Mayo Mom, which will be on Thursday, September 6th at 11 a.m. The topic will be depression in children and teens, and our guest will be Dr. Jared Leffler, who's a child and adolescent psychologist. It's going to be a great discussion about how you can pick up the signs of depression, how its diagnosis is made, as well as how the treatment is recommended and takes place, and many, many more things. So please join us, and we hope to see you then. You can catch at noon o'clock Central Standard Time, Mayo Clinic's next Facebook Live video Q&A will be with Dr. Dawn Musselum, Mayo Clinic, Florida, who will be discussing cancer-fighting foods and more. So please join that discussion and follow along as well. Thank you, everyone who joined us, and have a wonderful day.